very much, Rich, for the nice introduction. I'll expand on that a little bit by saying I came to Seattle almost by accident in 1973 because I'd met Art Ward in Bethesda and he offered me a place in the residency. That was before the match. And so as chairman, Art took whomever he wanted to, and he liked to hire people who had done bench science as he had. I'd then really actually never been to Seattle, and I doubt Art discussed my appointment with anybody else. Fortunately, I got to know the Ojiman family soon after I arrived because George supervised the research I'd brought with me from NIH. For the first time I met Jeff, he was 5. At that moment, he seemed much too overactive to be chief medical officer material.
He's still overactive.
He was probably thinking in numbers, not words. The city was just as different as Jeff was 50 years ago, and medical care was on the front end of a huge transition. Medic One had gone into service in 1970. And it was my good fortune to know all of the principals involved in that endeavor. They were all remarkable people. The events were transformative, and because I like to write, I interviewed them all and I wrote a book about it. This is a book about Seattle Medic One. The story of Seattle's Medic One is actually the story of all pre-hospital care in America. When residents were on the Harborview service as R2 in those years, it was our responsibility to see the neurosurgical patients in the ER. Note that the designation for the location of emergency services was then still the emergency room before it became a department. And that metamorphosis, we will see later, was not an easy one. But in 1973, the ER was simply a room which one entered from the south end of the building. There was but a single drive-up ambulance lane that circled around in front of a waiting area staffed by one nurse at a small desk. Behind that and down a short flight of stairs, along a hall were 8 or 10 curtained off cubicles for patients. When an X-ray was required, the patient had to travel down a long corridor to radiology. When an urgent cranie was necessary, 2 residents, if they weren't very big, loaded the intubated patient onto the tiny, now out of service elevator on that south end of the building, one bagging the sick person while the other one pushed the elevator buttons and pulled the gurney. The operating rooms were on the 7th floor of the original building, now called the Center Tower, and they were as antique as the elevator. There was no CT, no MR, no sophisticated digital angiography to guide us. DNA was something that with great difficulty could be extracted from cells. We had physical exams and primitive angiograms, which at Harborview we did ourselves by sticking the carotid directly. There was also a machine designed to locate the midline by ultrasound so we could tell which way things were shifted, but it never worked. A few years prior to that moment, the entire understanding of what it meant to be dead had changed when Bernard Lown at Harvard built a machine that would both cardiovert and defibrillate. Prior to the invention of this defibrillator, if your heart stopped or beat abnormally enough, you were dead, and the ambulance in which you rode, then a slightly modified station wagon-sized affair, stopped only long enough at the hospital for death to be certified, and then it turned into a hearse and took you straight to the morgue. But after Bernie Lown built the first functional defibrillator in 1960, the idea of brain death was introduced, to some stout resistance initially, but eventually that concept was accepted. So all of a sudden, a stalled or quivering heart didn't necessarily mean a person was dead. The Uniform Definition of Death Act was first proposed by the President's Commission of 1981, but it wasn't passed into law in all 50 states until very recently. Even now, the standard criteria for declaring a patient brain dead are not uniform, either in the US or the rest of the world. All of this is but preamble to the opening of the Medic One book that reads this way. Eldon Holmes died early in the morning of the 29th day of February, 1972. His wife heard a loud crash when he fell over, purple-faced, because his heart had unaccountably stopped beating. Her call to 911 at 7:14 in the morning produced a Seattle Fire Department engine at their apartment by 7:16, and one of the brand new Medic One rigs a minute later. The paramedics found a middle-aged man on the floor, not breathing and pulseless. Even a few years earlier, Mr. Holmes would have been pronounced dead in his apartment. The last thing he remembered of that Tuesday morning, the final leap year day in February, he was drinking coffee in his kitchen. But thanks to the medics, who promptly intubated him and shocked his heart back to a normal rhythm, a few weeks later, he walked out of the hospital. In Seattle and all over Washington state, it is now even more difficult to die at the scene of a cardiac arrest or a major trauma than it was 45 years ago. The paramedics won't let you. From after World War II until Lyndon Johnson signed Medicare/Medicaid into law July 30th of 1965, the emergency care provided by hospitals, doctors, and nurses hadn't changed much since Abraham Flexner published his paradigm-changing report in 1910. An emergency room in most hospitals was just that, a big room full of acutely ill people, some sitting up, some lying on gurneys divided by curtains into almost individual spaces. Patients might go or be taken by ambulance to a private hospital if they had means, but the ER itself was similar everywhere in America. Sick and injured patients either sat expectantly in a reception area or lay in cubicles waiting until a junior house officer or a nurse got around to asking them what was wrong, taking their vital signs and examining them. Then they waited some more until a clerk appeared to find out if they had insurance, cash, or nothing. All of these activities were seldom hurried because in truth, there wasn't a great deal to be done for any of them. Diagnosis was based on plain x-rays, simple blood tests, and physical exam. The drugs available were limited, and titanium was still only an element to be mined from the earth. Almost all doctors and nurses then considered it a part of their professional obligation to provide care to poor, sick, and injured patients when they showed up for treatment, regardless of their ability to pay. My dad, a thoracic surgeon, claimed that at the first monthly meeting of his county medical society, a dozen years before Medicare/Medicaid, the treasurer reported a total cost for treating unfunded patients admitted to that county hospital's emergency room for the previous 12 months. The president then added 2% for inflation and assessed each member of the society an equal portion of that total to provide care for all of the patients anticipated in the ER unable to pay during the coming year. The physicians each absorbed the loss of their professional fees in that setting as a responsibility. Then came pre-hospital care. The odd truth of the matter, however, is that pre-hospital care didn't start in Seattle or even in the United States. It had its origin in an unlikely place and was authored by an unlikely person, Frank PANTRIDGE. That's Frank. He was Irish. As a medical student in the late 30s at the Royal Vic in Belfast, he got diphtheria complicated by heart block, and his education was delayed so that he graduated just in time to enlist in the medical corps of the British Army and be sent to Southeast Asia. After the fall of Singapore in 1942, he was captured by the Japanese and assigned to slave labor building the Burma Road. He somehow also survived that trial along with but 182 of the original 1,600 men with whom he had been imprisoned on the Thai-Burma border. He returned to Belfast, finally recovered, trained in cardiology, and then he joined that faculty. In those years in Ireland, if you were sick, someone called your family doctor, who might get by to see you in a week or two. If your heart wasn't beating properly, that was likely to be too late. Pantridge knew about Lowndes' defibrillator, and he got the hospital to buy one, which then weighed 90 pounds. He loaded it into the back of an old ambulance, along with a couple of house officers, to take the ER to patients rather than waiting until they were cold. Pantridge established a notification system that went directly to the cardiology department at the Royal Vic. And after they were summoned to the house of a cardiac patient, they unloaded the machine and plugged it into whatever current was available. And in Ireland at that time, there were several different types. That was the beginning of pre-hospital care. Pantridge published his data on 312 patients treated over 18 months and provided at least some basic evidence that it worked. Enter now the Seattle connection in the form of Leonard COBB, then the young chief of cardiology at Harborview. After he read the Lancet paper, an enthusiastic Len COBB began to think about how he might bring the sophistication of the Seattle medical community to the ideas Pantridge had shown at least sometimes worked in Belfast, and to improve on that system. The way to introduce new ideas and strategies into medicine, COBB knew, was with data. He wanted to be able to demonstrate that pre-hospital care increased the number of lives saved out of the total number of patients at risk. Initially, he was interested in tracking only the cardiac events. By 1969, the confluence of ideas then flowing together in various branches of medicine, especially in medical schools and teaching hospitals, enabled a whole prescription pad of new possibilities. Not only were chemical and electrical cardioversion and defibrillation established beyond doubt, the drugs and equipment for doing these procedures had been simplified and compacted. Coronary care units and other intensive techniques were part of routine inpatient treatment at major centers, and they were moving out into larger community hospitals by then as well. At the same time, newer drugs, more options for emergency treatment, effective mechanical ventilation, and better emergency room technology rapidly appeared. Still, by far the major impediment remaining was to get patients to the hospital in time. As a young academic looking for a career niche, Len COBB, who is 90 years old and still vigorous, by the way, was the ideal, thoughtful clinical scientist to help build a system for taking these emergency medical needs out of the hospital and directly to patients with severe cardiac emergencies. But he needed help, and his first ally wasn't a doctor or even a college graduate. Gordon Vickery was by then the Seattle fire chief, but his first job, interestingly, was working for a rural undertaker in Snohomish. After graduating from high school, he joined the Seattle Fire Department, and over the next 15 years, he worked his way up through the ranks. In 1963, Vickery replaced the very frugal William Fitzgerald, who had then been the fire chief in Seattle for exactly a quarter century. Fitzgerald's mission in life was a little different than that of most city executives. He always wanted to turn money back to the city council at the end of the year. While this largesse resulted in more cash for the city treasury, it also meant that the fire equipment was all older than Fitzgerald was by the time he retired, because there'd been no expectant replacement program. In fact, nothing was replaced unless it couldn't be found, stopped running, or completely disintegrated. Chief Fitzgerald had, after all, lived through the Great Depression. As a consequence for Vickery, as the incoming chief in 1963, a lot of the recruit training would be about finding a way to replace sections of hose because they had burst and been repaired so often. It was, as surgeons happening on difficult times in the operating room have been heard to mutter, like sewing moonbeams to flatus. Firefighting had changed nearly as much as emergency care over those years, with better fire alarm systems, smoke detectors, and stringent building codes, all meaning fewer big fires to fight. So Vickery's budget was at risk. The Seattle Fire Department already had a system of aid cards in place to provide basic first aid, and Vickery immediately saw that expanding pre-hospital care through the fire department might protect his budget. All that COBB and Vickery needed then was someone to implement their ideas. Fortunately, he was right down the hall. Few of the old timers will remember this picture. Beginning in 1973, the first thing chief residents told their juniors and medical students about to start a rotation in the Harborview ER was, "Don't piss off Dr. COPASS." It wasn't that Mike COPASS, the newly appointed director of emergency services, was unreasonable or quarrelsome, although he once did describe himself to a medicine resident within my hearing as short, fat, and angry, winking at a bystander after he said it, but he certainly had his own inviolable view of the world. And this medical and social worldview had evolved from the time he was a little boy growing up in Magnolia Bluff in Seattle. There's the great Mike COPASS waiting for his daddy to come back from World War II. By the time I met him, he was already iconic. No matter who was hauled in, those patients weren't bums or addicts or derelicts or gomers who happened to show up when Mike COPASS was managing the ED. They were then known as the unfortunates. COPASS was descended from a long line of intense Southern Baptists who believed in God and good works, and maybe even in good works first. This was long before cell phones, and Mike always carried around a huge fire department radio phone designated Portable 55. He often listened to chatter from the paramedics and offered them advice in the middle of the night over the thing. In one famous story, the paramedics wanted to intubate a woman who was having repeated seizures. Their HMC control told them not to, but to give her IV Valium. This debate went on for a few minutes, and suddenly over the radio phone at 3 a.m. came COPASS's voice, "Push the Valium." And of course, the fit stopped. But Mike's legend evolved from more than the ED itself. He knew all the cops and firemen in town and had a unique standing with them. He also had a series of old BMWs that he worked on himself to more or less advantage, and he parked them just behind the ED in a special assigned slot. As he was leaving late one fall night, the white one wouldn't start. He decided to take the number 3 Metro bus downtown to 3rd and Pike, transfer to the Mercer Island bus, and get home. The street was empty and dark when he got off near what was then the downtown Bon Marché about 11 at night. And as he stood there alone at the bus stop, holding his always present small doctor's bag stuffed full of neurology gear, 3 young toughs approached. He demanded his bag and his wallet. Mike said firmly no. After a couple of minutes of increasingly intense debate, one of the young men, most unwisely, pulled out a knife. Mike hauled up his radio phone, with a huge mother this big, and he said, "Help the officer. Portable 55 needs assistance at 3rd and Pike." Within about 30 seconds, half the cops in the downtown corridor were there, and within another minute, almost all of them had screeched up. As the Mercer Island bus pulled to the curb, Dr. COPASS calmly stepped over the 3 handcuffed guys on the ground and boarded. The fellow lying on his belly who had pulled the knife looked up at the police officer standing over him and said, "Who's portable 55?" Over the next 20 years, nearly everything that happened in the ED was designed and determined by COPASS. Medic 1 had begun to treat effectively not only cardiac events, but every sort of trauma, and to rapidly transport patients to appropriate levels of care. Because HMC is, of course, the only level 3 trauma center in the WWAMI region, the most seriously injured patients always came here. But after emergency medicine was recognized as a specialty, the ACGME would not consider certifying resident hours spent in an ED not at least partly managed by a board-certified emergency medicine doctor. And Mike COPASS is a neurologist. So he was rather unceremoniously pushed aside, and it was several years before the feelings of the COPASS versus the ED docs factions were soothed enough to restore camaraderie in the new emergency department. The final player in creating the success of Medic 1, Airlift Northwest, and the statewide emergency transfer system, what was then still recognized as a GP in TWISP, named Bill Henry. That's Bill up on top of the Cascade Ridge, just behind my cabin over there. Doc Henry was the only physician in the Methow Valley for 40 years, and he was instrumental in helping the Washington State Department of Health produce better, safer, and more equitable methods for moving acutely ill patients to bigger centers. Very sick and injured patients stuck in small rural hospitals were at great risk without specialized care and equipment. A bill proposed to the legislature was aimed to provide emergency medical services and trauma care to all residents of the state, regardless of a person's ability to pay. The original committee met regularly in a room at the Ellensburg Holiday Inn, now most vividly remembered by those committee members for its hideously ugly red curtains, to discuss how to employ first responders and paramedics, and then how to efficiently get very sick patients from rural areas to higher levels of care. But there were a lot of conflicting interests, of course, all across the state, as well as all across WWAMI. As COPASS recalled the early gatherings, Bill Henry was a voice of reason, so that after a good bit of squabbling, eventually the bill was passed in large part because of Dr. Henry. As a consequence, statewide trauma and other emergency care is now available all across Washington, and because of Harborview's unique standing, over the entire WWAMI region. In the mid-1960s, the Seattle Times quoted Chief Vickery describing department responses to 1,451 life rescue emergencies the previous year, or about 4 calls a day, 4 a day, remember that number. These were still the fire department aid card runs. Vickery had added, life rescue service is strictly an emergency service. It's not intended for transport such as an ambulance provides. In this very brief statement, the very clever chief let the public know when to call for help, and also informed the private ambulance companies that he was not out to steal their trade. In King County alone, Medic 1 now replies to more than 500 calls a day. Heart attacks, bleeding, and trouble breathing were common calls for help. The newspaper story continued. Of course, those in distress had to contact the department somehow, so Chief Vickery advised learning the telephone number, not yet 911, but then a now antiquated 5 digits preceded by an abbreviated word, Maine 23344. He ended by saying, "Our life rescue service is an added service beyond what a fire department normally is expected to do, but we're happy to provide it. What better service can you provide than saving lives?" Gordon Vickery, believe me, understood how to manage the press, and he was very, very effective at it. Though the aid cards had been in operation for 6 years, those firefighters who rode in them initially were trained only in advanced first aid, a comparatively modest certificate supervised by the state and requiring little medical oversight. Vickery was eager to help build a much more ambitious system, and he was capable at urging city government to cooperate. Of course, Len COBB wasn't the only bright young cardiologist who read the Lancet, and doctors in big cities like Miami, Columbus, Pittsburgh, and LA were also busy trying to design pre-hospital care programs. In the few places where the work was cooperative, in a few places the work was cooperative, but most often there were competing forces, and in those cases, failure was the rule. Like Seattle, the successful Miami program had been built on cooperation, and it also began to function the same year as did Medic One. Grants to get started on those ventures were available through the NIH, and in 1967, COBB had applied for one, but was turned down. In the fall of 1969, a Seattle Fire Department newsletter announced that starting October 14th, 10 Seattle firefighters will be assigned to Harborview on an indefinite detail to commence study preparatory to placing Seattle's first mobile coronary care unit in service. They were eventually funded, and Len COBB influence could be felt on the subject of heart attacks. A new grant from HEW was part of the Lyndon Johnson Great Society move, and eventually went to the university with COBB as the program director, awarding about $500,000 over 30 months for salaries, equipment, and drugs. Each firefighter was then making about $10,000 a year, so the grant ensured that the city of Seattle paid nothing more for the ones assigned to Harborview. That soothed the mayor and the city council, both very wary of the whole idea in the beginning. Newsletter readers learned also that about 60% of heart attack victims died within 1 hour of the onset of symptoms, and that the majority died far removed from intensive care units found in modern facilities. Len COBB was sure that the data he intended to collect would prove that driving the emergency room to the patients rather than waiting for them to appear would save lives. And with the support of a great deal of data, he did prove it. The first actual vehicle the firefighters would take into the community was a walk-in type van, large enough to stand and work on a patient, and loaded with the usual first aid equipment. But in addition, it carried an EKG machine and a portable DC defibrillator, although at 33 pounds, the Physio-Control early life pack device was really only almost portable. The firefighters immediately christened the unwieldy, underpowered boat of a van, Moby Pig. It had a trial run on the streets in October 1969, and although a lot was expected from the first super ambulance, it immediately bottomed out. The first class of paramedics were to all learn it didn't work very well, not because the idea was unsound, but because Moby Pig was set on an Oldsmobile motorhome chassis and was poorly designed to serve as an emergency response vehicle. Just check out the tires on this puppy. It had handled well enough on a 3-day journey from Hutchinson, Kansas, where it had been assembled, but that trip was on the interstate. When it arrived in Seattle, the suspension struggled when it bounced up and down the hills, and it was vastly underpowered. Furthermore, Harborview, as we all know, is at the bottom of one hill and at the top of another. Moby Pig could go downhill fast enough, though bottoming out all the way, but the James Street Hill often proved insurmountable trying to return. Driving east uphill after leaving Harborview, it stalled and died by the time it reached the top at Broadway. The new rigs are designed specifically for their purpose, and the 26 paramedics in each class trained here at Harborview know how to use them. You probably all looked into the back of one of the rigs. Here's some early aid car people trying to help somebody in a parking lot somewhere. And here they're hauling some guy up out of a hole in the ground with trying to get him out of the hole. The alarm center where 911 calls now arrive was originally as primitive as Moby Pig. Information first came in from alarm boxes until the entire system was made digital. The alarm boxes were subject to pranks, malfunctions, and mistakes. Intersections all over town had to be localized to which station was nearest, and for years this was done by hand. Oh, that's the 17 class of paramedics. This is station 2. That's where the original alarm center was located when we still had alarm boxes, and that's the inside of the thing. Here is a early watch station where they get calls coming in to tell them where to go. And this thing is I'll show this to you later more closely. Some sort of information was transmitted along that paper tape, but I don't know what it was. They had a paper locator, which showed intersections between every corner in Seattle and which fire department was closest. And they had this funny looking thing where it put pegs in to let them know where people were. And then this is that paper tape I showed you. This is what it looks like now. The alarm center is downtown in Station 10. And you can see that things are much more digital than they were. An urgent call to the alarm center at Station 10 near Pioneer Square is now answered by trained firefighters and the information computerized in real time. When enough data is gathered, they push a commit button on the computer, often dispatching help within 30 seconds. It's just another view of that. Just before noon on September 24th, 2015, the 8 members of Team 2 were standing inside room W251 in the Harborview NCCU, discussing the occupant of that bed with her nurse. The patient, an older woman with a long history of hypertension, had bled from an aneurysm 12 days prior and been operated upon the night of her admission. She was recovering well, eating, out of bed, and able to walk to the bathroom with standby help. The bedside nurse thought she might soon be fit to leave the unit. As the staff discussed her progress, one of the assistant NCCU managers poked her head into the room and said, "There's been a big disaster downtown and we're getting survivors. We'll have to make room for them, so move anybody who's able to be transferred to the wards as soon as possible. We got 40 minutes. One of the junior residents stepped to the nurse's station across the hall to look at bed availability. There he found a group gathered around a computer screen watching one of the Seattle TV stations reporting live from the scene. There was wreckage scattered along the 175-foot high Aurora Bridge connecting Fremont to downtown Seattle, and a Ride the Ducks vehicle slammed into the side of a tour bus. The entire left side of the bus had been peeled off like the top of a sardine can. Bashed in cars, debris, glass, fire engines, and Medic 1 rigs occupied both lanes of the bridge, along with 20 Seattle firefighters very hard at work. Oops, not that. 4 people died on the bridge, and another young woman with a profound TBI was pronounced dead by me in the TICU. All the others survived because of Medic 1. The current director of the ED, Steve Mitchell, said later, "This accident was a very different thing, but we were all ready and it worked perfectly. Together we determined who should be transported to Harborview and who should stay in the local community hospitals. Initially, 15 patients with major trauma came directly to Harborview, and 2 others were later transferred in from hospitals where they were discovered to have more significant injuries than could have been known on the bridge. Within an hour and 41 minutes from the time of the initial call to the alarm center until the last rig left the bridge, Medic 1 transported all 51 patients. As a manager, Steve Mitchell said, "I felt like a proud papa." In 1974, Morley Safer, one of the early hosts of 60 Minutes, was shown riding in the back of a Medic 1 rig while on the air. And he said, rather famously, "If you're going to have a heart attack, have it in Seattle." He was right. Harborview paramedics have now spread out all over the state. It's hard to die where you fall in Seattle, or indeed anywhere in Washington. The paramedics simply won't let you.